Okay, this case, we've just seen it. 56 years old, progressive worsening of neurological status in a patient that had a recent bone marrow transplant. And you see this little little lesion everywhere, this scattered little lesion here with the ring enhancement. This is post-contrast T1. You see all of the brain into the deepest area. On FLAIR, you can hardly see things because the lesions are so small. You can barely see any necrosis. On diffusion, it won't be really helpful because you don't have enough necrosis, and this is a case of nocardiosis we're seeing right now. Okay? Then I will give you the microphone, please. A patient, a woman, 56, HIV positive, cognitive disorder. You can easily also imagine she might have headaches.
Well, yeah, there seems to be a hydrocephalus, mostly prominent in the posterior horns, and there is signal abnormality. Just, I think, in the periventricular aspect of these horns, especially, I think, extending to also involving the perimesencephalic cisterns, I think, huh? Maybe I'm right. Mm-hmm. Somehow hyperintensity is over there, yeah, in perimesencephalic cisterns. And also in the periventricular areas, as I mentioned earlier, there are signal abnormalities, diffuse, and the sequence is post-contrast.
T1 post-contrast.
T1 post-contrast, so they are enhancing lesions. So based on that, I mean, cryptococcosis, things like that are more prominent.
It's anyway, it's a meningitis. It's a leptomeningitis.
Mm-hmm, yeah.
And usually, most of the time, we can hardly state what kind of meningitis it is. What's striking here, this meningitis was rather focused around the skull base and especially around the mesencephalon. And when you see along the vessels, you can see an enhancement that may cause vasculitis as well. Actually, this patient experienced a stroke. Actually, it was none of the germs I've shown you. It was a tuberculosis, only because, anyway, any kind of infection may occur, especially in this patient having immunocompromission. Well, next. It's a male, 45, HIV positive, having a transient diplopia.
You can see bilateral hyperintensities, periventricular, in the subcortical white matter.
Also, yeah. Yeah, it's rather periventricular, but also involving the subcortical areas, the U fibers.
There is no signal intensity in the diffusion sequence and no visible contrast enhancement. And considering the patient has HIV, it could be an HIV encephalitis.
That's right, exactly. No enhancement and actually no dark, no hypo-intensity on T1 as well, which is quite different from PML. Then here is...
Okay, here we see progressive hyperintense spots in the periventricular space, which are quite symmetrical, I would say. In 2017, it's progressive, definitely. And it extends into the subcortical white matter. And considering this is also an HIV patient, I would say it's a progressive HIV encephalitis as well. So
That's right. Actually, here, as you say in the books, usually it's described that the HIV encephalitis spares the U fibers. And in our experience, usually the U fibers can be also involved, especially when the encephalitis is quite severe, as in this case. The fact is that it's rather periventricular, quite symmetrical, and this is a major option. You may have some additional feature, especially on T1, wouldn't show any dark hypointensity as well. Here it's a difference.
So looking across, so in the left, the right frontal lobe and the left prior to it, there's some hyperintense lesions. It looks like it's also got diffuse, very electromeningeal, very smooth enhancement, no restricted diffusion, and multiple blooming artifacts on the signal-weighted image on the right. So I wonder whether this is like the way he's on nivolumab, so this could be like some chemotherapy. This could be some sort of drug-induced press, but it's not really in posterior fossa, or some sort of immunocompromised opportunistic infection.
You mentioned Press syndrome. That's what
It's more posterior though, rather than.
Actually, there's a very there's a very dark hypointensity, which is quite unusual. Usually, there's a Press syndrome. The lesions are quite usually more extensive, but it's a quite interesting idea. Usually, it's not so dark. What else? Cerebellum is involved as well. It's not a major differential feature, but here it's really to deal with the possibility of HIV encephalitis. Here there's no HIVs, and it's clear, and it can be related as well to PML.
Yeah, asymmetric. Yeah.
Another case.
Okay, so there's involvement of the left occipital lobe and frontal lobe. And there's no contrast enhancement, if you see in the images. This is quite markedly hypointense on T1, and it involves the subcortical fibers. So, this could be PML as well.
That's right. Okay. Remember, this really dark hypointensity, subcortical hypointensity on T1 are very suggestive of PML. Of course, the clinical story and so on is very important. But when you have this really dark lesion in immunocompromised patient, subcortical, you see the cortex is spared in this area. And obviously, when you have additionally on diffusion this little rim of eye signal, which is usually due to restriction of diffusion, which mentions the edge of demyelination, is very, very suggestive of PML. Of course, it can be, usually it's multifocal. Sometimes it's unifocal as well. Then it's quite tricky. And the enhancement is possible, but not constant at all.
You see hyperintense lesions, hyperintense white matter lesions in the right frontal lobe, which is hypointense in the corresponding T1 sequence. I think you see a small microhemorrhage on the SVI sequence as well. which are cortical appearance. Well, it's asymmetrical, so it's mainly dependent on the right side.
Again, yeah, very dark, very hypointensity on T1. Contrast enhancement is not present in this case.
Not proven, no.
This feature was just mentioned to now. We really see in not all patients, but in a part of patient, especially in patient experiencing immunodeficiency related to treatment, this little cortical hypointense rim on T2 star and SWI. Here, sometimes you have a little spot into the lesion, but it's also a very interesting feature when it's present with diffusion, the rim on the deepest side, and this is a dark rim on the superficial side, very, very suggestive of. Here you have other feature, this deepest eye signal rim on diffusion, okay, and also perform spectroscopy where you can see a major lipid peaks in this area. Lipids are not very specific, especially in infectious disease, but anyway, remember the dark T1, PML as well. Okay? Okay, then I guess we'll here back. We'll have seen several.
We've again got a T2 hyperintense lesion and T1 quite hypointense lesion with a bit of a TWI, slightly bright rim, non-enhancing, and again, looked to me like PML.
That's right. The fact was that it was the same patient previously. The fact was that we introduced the treatment in order to try to stop this lesion. And you see 1 month after immunity was in a certain way recovered, you see this little lesion with enhancement, an increase of different lesion here, and the enhancement all around. And then
Is it just simply iris, even
That's
though
right.
it is in completely different area than the primary abnormality?
Here was the previous one, but you see that you have an increase of lesion everywhere. Here are the previous one. And you see new lesion, and lesion are also increasing as well. Then it's quite disturbing as well. And you see all this little enhancement are also very, very suggestive of the reconstitution of immunity.
So is it typical for PML in the iris case that firstly, the treatment is not the specific treatment for the PML, but for the underlying condition for immunosuppression?
Please.
The first question is, treatment is because of the underlying condition, in this case HIV. Is that right?
It was, I guess, was it HIV? I don't know.
Yeah, I think. So he got antiretroviral therapy.
I guess it was maybe because of other disease. Anyway.
Anyway, but the treatment thing is the treatment of the cause for immunosuppression.
That's right.
Okay, and
then,
is it typical for the iris that there are additional lesions at different?
When you have iris, you may experience additional lesion, of course, and real worsening.
which were previously just small lesions that were undetected.
Well, if we were not able to detect, I can hardly say you that they existed
But it's typical
before.
that there are more lesions.
Of course, yeah.
Okay.
And yeah. Another case?
There's on the right side in the parieto-occipital area a ring lesion with in the T2 flare hyperintense ring in the with contrast enhancement, and there is in the center in the diffusion there is also hyperintense ring, and so I think it's like infection with aspergillus or another.
You also have, you see here, a
meningitis is
enhancement deep into the sulci here. What you may then leptomeningitis,
and the cerebral
deep lesion, in a certain way abscess-like.
So, aspergillus fumigatus, I think, is a...
Well, tuberculosis, usually you don't have such a large leptomeningitis. Usually it's focal rather on the skull base, but why not? You may also observe this leptomeningitis. In HIV, what is the most common
Toxoplasmosis?
Toxoplasmosis, right? This is the most common. Usually there are not such a leptomeningitis in toxoplasmosis. But it's not specific. And the fact is that here it was a toxoplasmosis, here, but also you see all this white matter lesion was witnessing the encephalitis related to HIV. Okay? Another case. You can keep it.
There's in the deep basal ganglia region on the left side, thalamus region, a lesion with T2 peripheral hyperintensity and a central target like zoom.
Sir, central target sign? Not yet. Not yet.
I think in the flare sequence in the first there's a target in the center.
Okay, so now, I show you the target sign.
and in the contrast.
Here, it's the same lesion. Here you have a small eccentric target sign.
And there is diffusion restriction in the peripheral zone, and there is in the SVI or in the signs of hemosiderin bleeding.
Yeah.
And this is the eccentric target sign in the post-contrast, so that's findings for toxoplasmosis.
That's right, okay. Here's a concentric target sign, here's the eccentric target sign, and in HIV, toxoplasmosis is really the most common disease, infection. Okay, another sign, just another lesion, maybe just to show you another example. You see this deepest lesion, okay? You don't see any leptomeningitis. Well, it's not necessary, but you have a little lesion in the deepest part of the brain with this enhancement, surrounding enhancement here, and this little central eccentric enhancement. This is the eccentric target sign, which is really quite a quite good sign. On T2s, and you have this concentric target sign with inner high signal, outer dark signal, and again high signal. Perfusion will help you to distinguish that this is not highly vascular. Actually, there's not increase of perfusion. You don't have any ICBV in this region like you can observe in metastasis or in, for instance, rather metastasis than glioma, but here metastasis. And on spectroscopy, what you observe, it's when you want to distinguish this from a tumor, okay, you have a little drop of NAA, but quite similar to the choline, but you essentially see a very high peak of lipids in this area, a double peak of lipids, 1.3 and 0.9, which are quite suggestive of the infection here. Then here, again, it's
Superosmosis.
That's right, toxo. Okay. Next one.
So it's a post-liver graft, so immunocompromised patient, and we see multiple lesions, bilateral, with different dimensions. They are hyperintense. Some of them have ring-shaped. And most of them are deep or subcortical. They don't show much enhancement.
A little peripheral.
A little bit, okay.
Maybe vasculitis as well?
Yeah. Some of them might show incomplete ring enhancement. Is that it? We could think of aspergillus.
That's right. That was a case I've just showed you with more features, and you see all this the deepest brain lesion, which reveal a hematogenous spread, and it was additionally you see on top image a narrowing of the middle cerebral arteries here, especially here. Then it was associated with this vasculitis. Okay, and on the lung CT, you see this typical cavern. Well, I miss these words on the lung imaging. Next one.
Yeah, so you see a paraventricular high intensity on the left side of the lateral ventricle, and also it has not ring-shaped, but it has. Is the one on the right, left, totally on the left, contrast enhanced? Is it T1 with contrast? This one?
Here.
Yeah. So it has no contrast enhancement. It has diffusion. It's reduced diffusion, and yeah, could fit with, and it has a leptomeningeal.
No leptomeningeal. No leptomeningeal enhancement. No vasculitis.
Maybe also the same as the last one, Asperger's.
It's the same as the previous one?
Yeah.
Okay, then what kind of family of?
Asperger's.
Okay, it could be in a certain way. Here, then remember you have a sinusal infection, and then this struggled many weeks to try to control this sinusal infection. Here, at this time of the story, there was still an infection in the ethmoid. What's striking is the dark, the hypointensity in the ethmoid, which can be quite suggestive of fungi infection. Okay, and then the lesion itself here, we can only say that it could be related to this fungi infection of the sinus, and then in this case it was not aspergillosis, it was mucormycosis, another fungus. And of course it's impossible for us to do the proper diagnosis. It can also be a stroke. It looks really like a stroke, but actually it was an infection. Here's a case here. Then he has already an infection, leptospirosis, but it's not related to leptospirosis itself.
So we see these lesions in the deep brain area and in the basal ganglia. Those are in the FLAIR images. Hyper intense with a rim enhancement and a rim diffusion restriction, or like a restriction to diffusion, which some leptomeningeal enhancement also.
Leptomeningeal enhancement.
Or not,
well,
I thought on the last
not
image.
Really, maybe here a point.
On the last image, yeah. Yeah, there.
Here, well, yeah. Probably something in this area. Don't really know if it's pachymeningeal enhancement or leptomeningeal enhancement. Anyways, there's a pachymeningeal enhancement here.
Okay.
Here, but probably due to lumbar puncture.
Okay. So maybe a fungal infection?
That's right. Okay. Then after, it's quite hard to say what kind of fungus that. Actually, remember when you have all those multiple lesion, especially in the deepest part of the brain, I mean, suggesting an hematogenous spread with this eye signal on diffusion due to restriction diffusion, this little hemorrhage, surrounding hemorrhage on T2 star or SWI. Contrast enhancement is possible in such area. Remember of fungi, and here there was again a pulmonary infection in this patient, and it was again a mucormycosis. And it may look very similar to aspergillosis, but for us, let's say it's impossible to really discuss the differential diagnosis.
Well, there are bilateral, but mostly asymmetric involvement in the basal ganglia, I think, and also extending to periventricular areas. The type of the pattern of behavior is high in T2 with some restriction in DWI, and also partly enhancement in most of them, peripheral enhancement, somehow with eccentric type of enhancement in the left, as you are showing in the left lesion. I'm not. I could not identify any leptomeningeal enhancement. So we have both intraparenchymal, I mean basal ganglia, and periventricular involvement with eccentric enhancement, both sides, somehow with restriction. I think toxoplasmosis is a good consideration.
Of course, toxoplasmosis is always a good consideration, but you may also suggest
something else. I think In this case, we can also outline, fungal infections. Fungal infections could also have similar pattern.
That's right. Bilateral, deepest,
deep-seated lesions.
Deepest area of the brain. And actually, in this case, it was cryptococcuses. And it's quite tricky. Keep in mind always toxoplasmosis. And remember this message, especially then dealing with HIV encephalitis and JSA infection PML is rather interesting, but we've seen that it looks really, really different. Okay, the story is not the same. In PML, you may have focal deficit, while in JSA, it's usually a cognitive disorder and so on. You have focal lesion, very dark on T1 for the PML, while on HIV is rather this large hyperintensity periventricular and so on. Ventriculitis, of course, it's not specific at all, but remember of CMV and toxoplasmosis, always keep in mind, and they always have to look for it. Even if you have bilateral, deepest lesion in the basal ganglia and so on, consider all the fungal infection. But usually the context is really, really different. Patient with fungal infection, they really often have a very poor condition, rather intensive care unit history, while toxoplasmosis, it could be quite a bit different. Okay, then thank you for your attention.
Like aspergillosis, how is the course about 1 week, 1 month under therapy? It's possible to normalize? Or
to heal. To heal from, the prognosis is really poor. I wouldn't say a very stupid number, but in my mind, it's something like 90% mortality.
Yes, but the healing. When there is a patient with chemotherapy and immunocompromised, then he's finished. And he come back, with his immune status. It's possible that the focal lesions of aspergillus, for example, can complete heal. So you have maybe only fine.
Aspergillosis of the brain, I've never seen in my experience aspergillosis of the brain coming on his own. They always come from a unit of the hospital. They don't come with they don't have an appointment, a rendezvous. The condition is really, really severe. And it's almost in the natural history of the worsening of the general condition of the patient. His condition is getting poorer and poorer, and then he starts to have neurological disorder, and then you start to see all this, but usually in association with many different other failure of organs.
A question about the perfusion imaging. Shall we keep that till the afternoon?
Actually, the program is done this way. Then in this afternoon, we'll deal with perfusion, diffusion, and spectroscopy. And then we'll have a little bit more time to explain all the peak and perfusion. But if you have any question... Okay. Then thank you.